Well, firstly, welcome to this interview that we have today. Good day wherever you are. My name is Mayank, and today I'm joined by Professor Naveed Sattar from the University of Glasgow. He's a professor of medicine and, of course, needs no introduction in the world of adiposity. And today we're here to discuss perspectives on GLP-1 agonists and adiposity in Asian populations. Professor Sattar, thank you so much for joining us today.
Thank you, Mayank. Nice to be here.
And thank you again for your time. We're recording this interview, of course, from ESC in Madrid.
Yeah.
Are you having a good time so far at the conference?
Yeah, it's been good. Nice to meet up with lots of old friends and see what the up-to-date science tells us. It's all good.
Wonderful. So let's crack on. So today we're going to be talking about adiposity. Of course, we know that this is a massive issue in terms of scale of the problem and cost. And we're particularly interested today about how that translates to ethnicity. So my first question and point for us to discuss today is what are the general trends in obesity and adiposity that we should know about, especially when it pertains to Asian populations?
Okay, yeah. I mean, obviously, obesity and its rise is a major concern in high-income countries. We're seeing huge issues, which has really been because of two things. One, in a plus way, we have more people living longer. And most risk factors, lipids have improved, blood pressure, we've got better treatment, smoking has come down. But the major risk factor that's been going up in high-income countries is obesity. Now, it's actually also going up in Asia and the rest of the world. At the moment in time, the patterns of obesity in, for example, Asian countries partly depends on their level of affluence or poverty, shall we say. In high-income countries, the poorest people have got the most obesity. In low-income countries, it's the richest people have got the most levels of obesity, but it's going up in all segments. And in middle-income countries, it's broadly equal. So there's a transition going on. Obesity is going up. It's going up fastest in low-income countries, in those at the moment who are overweight, who are most affluent, but that will change over time as more fast food becomes available, as there's more industrialization, as more people are able to afford, got better, quality of life and able to afford more foods. That will shift again. And as also more changes in farming and other aspects happen. That transition happened in the UK, happened in America. Poor people used to work much more hard, had less money, less food, but at least are able to food rich foods. That's changed. And unfortunately, in the same way that we've seen the transition over the last 60 years in high-income countries, that transition is currently undergoing rapid change in middle income, and low-income countries will follow. But obesity is rising and is changing, and it will start to affect progressively over time more and more people who are less affluent.
That's a pretty scary thought, isn't it?
I tell you, it's a very scary thought, because one of the reasons that you and I can, I'm able to talk about it being a South Asian myself, is that we are South Asians, particularly South Asians. I mean, East Asians are somewhat different, but all Asians seem to be at high risk of type 2 diabetes compared to the white population. But in particular, in South Asians, not only are they at high risk of type 2 diabetes, but they're also at high risk of atherosclerotic cardiovascular disease, heart attacks and strokes. We don't fully know why that is, but my sense of it is that it's all to do with ectopic fat. South Asians, for the same weight as a white individual, if they're the same weight and they're putting on the same amount of weight, will put more of that excess weight into their central parts of their body, into their liver, that then will permeate into the blood in the form of high triglyceride. They'll put more of it in their pancreas, which will contribute to diabetes, and put more of it into their muscles, and possibly around other ectopic tissues, like around the heart or in and around the kidneys. That is accelerating cardio, kidney, metabolic disease faster in South Asians than it is in whites. In East Asians, the mechanism for raised diabetes, I don't think we fully understand. We need much more studies. But at the moment, for the data that we have in the UK, those who are in East Asia, in the UK, actually have a lower risk of heart disease than whites, yet they've got a high risk of diabetes. So there's a bit of a paradox. And I don't quite understand why that is the case. What I can point to is that paradox also exists in African Americans, who have more diabetes but less atherosclerotic disease, There, though, I know it's because African Americans, Afro-Caribbeans get less ectopic fat, yet they get more diabetes. But the reason they get more diabetes, I think, is to do with pancreas or insulin deficiency rather than where you put your fat. So it's different. So we need to factor all that in. But by and large, the groups that I worry most about are the South Asians, diabetes, and combined with more atherosclerotic disease, and all the things that come with that, more kidney disease, more heart failure. And also, with lives having improved over the last 50 years, with improved hygiene, less infections, more people are living longer to get these chronic diseases as well. And all the figures, if you look at in very major journals, are predicting the biggest rises in type 2 diabetes in one of the regions is going to be South Asia. So it's a worry. And with that will follow, even before the diabetes, the ectopic fat will drive more atherosclerotic disease. So it's a major one.
Absolutely. So you touched upon the epidemiological transition that we're seeing in some of the developing world. Would you also talk about some of these issues as they pertain to childhood adiposity? Because we're seeing that people are getting much...
Yeah, but you know why? People haven't realised this. A penny dropped for me recently. Certainly in high-income countries, if we've seen over the last 50 years a transition in adiposity in the obesogenic environment, me especially, compared to you, because I'm older, I grew up more of my life in a lower obesogenic environment. And I developed my habits in that, and hopefully I've managed to resist some of the pushes. Kids born these days, particularly in high-income countries and perhaps more middle, are being born in more obesogenic environments. So it's already hard for them, and it's even harder than it was for you and I. And I think the same thing is happening in low-income countries. Kids born there are certainly exposed to more food not grown or provided in the traditional manner, and they have more opportunities to overeat and probably have less opportunities to be physically active. So kids all around the world are now being born in much more obesogenic environments, and that's a major concern.
Right. Which is why, again, we need to emphasize, I suppose, from a cardiovascular level, the importance of primordial prevention and the influence of the environment.
Absolutely. I mean, if we don't change the environment, we cannot medicalize our way out of this in terms of giving, kids drugs to prevent that. That just seems crazy. It's got to be a combination of drugs and the right people at the right time, along with prevention. And hopefully the two things can coalesce to lead to a revolution in prevention. I hope that happens. If it doesn't, we know where we're heading.
Absolutely. So we're going to segue a little bit now. I think we spoke about fat mass. So BMI as a representation of fat mass.
Sure.
Versus adiposity as a measure of sick fat, and how those might have different implications. So I wonder what your thoughts are on certain types of ectopic fat accumulation, particularly in the liver. We know that fat in the liver, whether that's metabolic associated cirrhotic liver disease, or as it used to be called, non-alcoholic fatty liver disease, and how that pertains to this topic of diabetes as well as cardiovascular disease amongst.
Yes. Okay. Let me give you I can give you very quick answers because we published some of the best evidence there. South Asians with the same weight have said that they have more ectopic fat, and the proof of it is one of our papers where we meta-analysed all the studies that compared by MRI or CT scan liver fat in South Asians versus whites. And what we found was when we have the same BMI, South Asian people have more fat in the liver, and that was consistent in men and women more than any other fat depot. So that's probably but it's also the fat depot that's easiest to measure. We didn't see an excess of visceral fat. People keep talking about visceral fat. Not sure. It might be deep subcutaneous, I don't know. But certainly liver fat is higher. And the other thing that's higher in South Asians consistently all over the world is higher triglyceride. And in most people, higher triglyceride is a form of ectopic fat in the blood. So you've got higher, and that comes from more fat in the liver, exporting more VLDL lipid into the blood. That's what it is. And we know that high liver fat and high triglyceride both are precursors of high risk of diabetes, and liver fat particularly because it enhances gluconeogenesis. But we also, I think we've under-recognized that if you're pushing more fat in the liver and into the circulation, you are, through VLDL and remnants, you're also slowly accelerating atherosclerosis beyond all your other risk factors, which might be why you get more atherosclerotic disease in part for South Asians. So that's what I think.
And you mentioned the part about how the whole is, so the sum of the whole is greater than the parts. So each of these different systems that's involved then adds on disproportionate the risk, which is why South Asians are even more high risk.
I don't know about disproportionate. I haven't thought about it in statistical terms. I mean, liver fat is not independent risk factor for heart disease. I would humbly suggest. I've had lots of debates about this, and I'm supposed to write a paper which I haven't yet. But beyond its usual risk factors, it's the usual risk factors: lipids, blood pressure, diabetes that creates the risk. But it is, liver ectopic fat begets higher triglycerides, which begets more atherosclerotic disease on top of LDL. What I would say in a simplistic way is that South Asians who are born with less muscle mass, higher fat mass, and a lower capacity to store that fat peripherally, put it into their central organs faster, that then begets some of the toxic factors that lead to atherosclerosis and diabetes faster in South Asians than it does in whites and other ethnicities. And that's what happens. So we do need to stay leaner to prevent diabetes. We need to stay leaner probably to also reduce the risk of atherosclerosis. And we also need to be more active. But unfortunately, obesity levels are going up in South Asians. And for the same weight gain, we will more likely develop diabetes. And I know that in my family history. Both my parents have diabetes. My brother probably has it as well. And even I am at high risk of diabetes despite having a BMI of 23. It's there.
Yes, and you mentioned some very important principles as well in the last couple of minutes about what clinicians might face when they do see patients with multi-ethnic history.
So the way this works is every country, if it can, should have a risk score for diabetes. And you don't need to measure anything. You can do it on 5 or 6 simple questions. Your age, whether you're male or female, you can use body mass index, family history of diabetes, and there are some few other factors that can be included, like blood pressure and other things. But through those factors, you can reasonably accurately work out your risk for diabetes, because males have a higher risk than women. Age, risk goes up. BMI is the thing that pushes you to diabetes, and family history tells you about your genetic aspects. And then if you've got few other factors that will also improve risk. And if your risk score is high, then go and measure either glucose, if you can't afford hemoglobin 1 or hemoglobin 1, and do that. And in a paper we published in UK Biobank, in people between 40 and 70, if you measured hemoglobin 1 in 7 South Asians, one of them would have a hemoglobin 1 which was either in pre-diabetes or with diabetes. So targetable action. Whereas in white, it was like 1 in 33. So South Asians, you can do risk scoring. I'm not sure how well that is done. Or if you've got any concerns about family history or their adiposity, just measure sugar or hemoglobin.
Right. Very important points and very clinically actionable at the same time. We're going to transition a little bit to talk about a hot topic that I'm sure a lot of our listeners are going to be very interested in, which is GLP-1 receptor agonists. Now, they've taken over the world of medicine and cardiometabolic disease by storm. I think there's lots of pleiotropic effects that have been seen across the board. So my first question to you on this topic would be, how is the data looking for GLP-1 receptor agonists in Asian populations?
Okay, so I'm glad you asked me that. I mean, it's exactly a question that that we've tried to look at. It became curious to us when we were looking through and writing up meta-analysis. We were able to look at each individual paper of 9 or 10 major trials. And at each time, when you looked at the data, when it was broken down by ethnicity, Asians versus whites versus blacks, or race, maybe should we say, the Asian hazard ratio looked a little bit lower. So we put it together, meta-analysis, comparing Asians, their benefit in big randomized outcome trials compared to whites. And lo and behold, there was a significantly better relative risk reduction in Asians compared to whites, and the absolute risk reduction seemed to be around about double. So in other words, you would need to treat half the number of Asians to get the same benefit as you would whites. Wow. Now, I'm not saying that's definitive, because the number of Asians was relatively small, but it looked reasonably encouraging. I think what you can say from a guideline perspective is that GLP-1s work at least, we definitely know they work at least as well in Asians as the rest of the world, and potentially better than in whites. So that's kind of encouraging. So, and there are bits of evidence also that South Asians do really well with GLP-1s in terms of glycemic control compared to whites. Now, why that might be, it might be that simply that South Asians and our Asians in general tend to be smaller than whites in these trials. Is it that for the same dose they're getting a higher concentration of that dose because they're smaller per body kilogram weight? That might be it. Or is it the fact that Asians, their phenotype for developing the endpoints that were relevant in these trials, particularly atherosclerotic cardiovascular disease, is more weighted towards ectopic fat, diabetes, and those factors which these drugs are particularly good at addressing, and less weighted towards perhaps smoking and LDL than in whites. I don't know that for a fact, but that could be another possibility. Or it could be a combination. What I think we need to do now, though, is encourage industry to do more trials in Asian countries of these drugs, because that's where the future epidemics or the current epidemics are going to happen. These drugs, particularly the orals maybe, would be ideal in those scenarios, and we need to do those trials because they may have a substantial benefit in those communities, but it's only until you do the trials do you look at, you find the truth of efficacy and of safety, and that's what we need to do.
Absolutely. You mentioned a little bit about efficacy. So from a safety point of view, do we have enough trial data so far about how side effects work in Asian populations on GLP-1 receptor agonists?
I don't know. I have not seen enough data broken down by sort of race, whether Asians, if they are, on the plus side, if they are perhaps getting a greater concentration for body weight, which might explain more metabolic or vascular benefits, they could also be getting more side effects because they're getting a bigger dose per body weight. I don't know. I don't think anyone's looked at that. So that's something that that investigators who've got access to these data could look at. I don't think there's any evidence I've seen published to suggest that. And I guess the other question we would be asking is, what about muscle mass? If Asians as a group, or South Asians in particular, are born with lower muscle mass, is there a concern that we know that these drugs, in addition to lowering fat mass, also lower weight and muscle mass? Does that become a problem in South Asia in terms of pushing them faster towards sarcopenia? My intuition is no, because it looks like in general, in a trial we did, the amount of muscle mass reduction is proportional to weight reduction. And it's therefore and when people put on weight, they put on muscle. When people lose weight by any method, they lose muscle. But the amount of muscle that's left is proportional to your body. So your functional capacity remains broadly the same, if not better, particularly in lower limbs. So I'm not currently worried. I think one of the things I said, even at one of the talks I gave yesterday, and then the debate about GLP-1s and muscle, the key mantra I gave to people was, when people are taking a GLP-1, and after about certainly 3 to 6 months, when they stabilize on this dose, and they're, or the weight loss starting to plateau, they are, and they reduce food noise, if that's one of their benefits, they are more able to think about physical activity in a way that they perhaps weren't before, because they're lighter and they have less food noise. So they may be willing to engage in physical activity in a way that they never were before. And we need to capitalize on that as a medical professional to give them the agency. How do they go about doing physically active? What are the options within their community physically active? And open their minds to the range of activities that are available. And that's what we need to do, because that then is a win-win, help keep their muscle mass up and so on. Whether we also need to ask them to do resistance exercise, we could do, and that's very cheap. You can just do it against your body weight. You don't need any fancy tools. So again, but we need more data. Coming back to more and more data gives us more solidity in our observations and our recommendations for people.
Another question that I had was, from data so far in terms of longer term outcomes, how are we seeing people with GLP-1 receptor agonists in terms of, is there a possibility in the future to get them off of it? How do they then perform? And any tips and tricks for people who are prescribing patients with GLP-1 receptor agonists?
Again, I would go back to my last response, is that the tips are once people are on these drugs, and particularly getting towards the kind of plateauing of weight, and the food noise is still in good control, getting them to be physically active and improve their range of diets means that even if they have to cut them off their drugs, they may slow that weight regain. And in some small proportion of people, we have seen this, they have made such a big change in their lifestyle being on these drugs that even if you tailor the dose down to stop it, some people, a very small proportion, I suspect, can maintain that weight loss for a long period of time. They may eventually put the weight back on, but it might take a few years. So that perhaps they could come off the drug as long as they don't have another recommendation or another reason to be on the drug, like cardiovascular disease or kidney disease. If they don't have that and then they could potentially come off the drug for 3 or 4 years. And if the weight starts to track up again in 4 or 5 years, then they could get another dose. I don't know. All of these questions are up for future research, and everyone's journey will be somewhat different. The intention, though, for people who really do need it, who've got very high BMI to begin with or disease, is that they should be on these drugs for a long period of time, in the same way that statins and blood pressure, if they've got existing disease like an MI or stroke, or they've got kidney disease, and if you're giving them for those indications. But for people who don't, and but they don't have yet or end organ damage, but they have obesity and they want to lose weight over the next couple of years, and then see if that kickstarts better lifestyle, that would be, why not? Give them a chance.
Now, we've had a very eventful meeting so far, even though we're only in day 2 at the ESC. From your point of view, what is the one part about this field which is the most exciting for you?
Well, it's for sure. I think cardiologists, I hope they're getting it, that we can't just keep developing downstream devices and more drugs to treat end-stage disease. We just can't keep doing that because, we can keep doing it, but the flow in is so substantial and it's getting bigger. If we don't stop the number of flow in of people getting disease, it doesn't matter how many devices, whatever, the cost is going to go up and up. The healthcare complications are going up and up because more people are living longer with disease. That's not a sustainable model of care. We have to do prevention. And I think these disease-modifying drugs, GLP-1s, SGLT2s, and lifestyle combined with that or integrated with that, and food policy change, those are the higher grounds we have to go there. If we don't go there, frankly, I'm worried. And that's the bottom line. So, most people who are living with obesity do not wish to be living with obesity. So we've got to get away from that stigma. We've either got to help them with the environment or prescribe drugs when we can afford to, that can help them cope chemically against the environment or change some aspect of their body that changes their excess fluid or fuel or ectopic fat stress so that they don't get those complications sooner. Or they get them later than they would do otherwise too. So we increase healthy life expectancy in individuals.
Thank you. Now, we've spoken about all the exciting things that are going on in the field. For all of our colleagues listening in, if there was 1 or 2 particular gaps in the evidence where you see the most need for people to conduct trials and to gather some evidence, what would those be?
How much are you going to pay me to tell you this? I'm joking. Clearly, I've already said it. I think the gaps in evidence is great that we've got these trials mostly in high-income countries, but the big needs are middle and low-income countries. And I think pharma, are recognizing that they need to think about doing trials of some of these novel agents in those areas where the rapid rise of disease prevalence will be. And we need lower-cost drugs. We need to, those are the kind of aspects that will really revolutionize care. For me, that's probably the biggest factor by far is in terms of need. Other than that, there's a range of other trials. I think we've woken up to the fact that big weight loss in high income, people, you can see the data already. Wow, look at the heart failure prevention, or heart failure treatment gains. What about prevention of heart failure or AF? What about prevention of hypertension? What about prevention of kidney disease with these drugs, GLP-1s and SGLT2s? Move higher up in the chain in terms of preventing disease rather than treating people with end-stage disease. Even though the number of needs to treat are better there, but we can move upstream prevention. But of course, the drugs need to come down in price for us to do that. But that's what it is. And what about the effects of leaks and many other conditions? And people starting, rheumatoid arthritis, psoriasis. We've got sleep apnea. What about severe asthma? What about multiple other conditions that link to obesity? We need to do those things as well, and that's happening as well. So, it's good that we've got these drugs. I don't want everyone to be on these drugs by any means. I'd rather the environment change, but I don't see it changing fast enough. And if anything, it's getting worse in many countries. So we are where we are. Let's do the proper trials to help more people, and then hopefully the trials and the drugs, particularly GLP-1s, which reduce food noise, maybe they'll be a catalyst to help us change the environment. That would be a win-win. So that's probably where I would sort of, hope that we're heading in that direction.
Thank you so much, Dr. Sattar. I think this has been a fascinating conversation. I've enjoyed it thoroughly, and I hope that the listeners have as well.
Pleasure.
Thank you again for joining us.
You're welcome.